Hello, this is David Bishai, and this is part 2 of our lecture of healthcare cost and health insurance in the USA. In this part of the lecture, we're going to be discussing the Medicare program, and especially focusing on what it is, what it does, and how it's been used as a lever, a policy lever, to help control healthcare costs. So first, Medicare basics. Medicare covers all people over 65, as well as covering some permanently disabled people under 65. For instance, if one requires kidney dialysis, no matter what age, Medicare will be the payment mechanism in the U.S. It is a federal program, and states play no role. It's funded by a payroll tax on working people, and so in that sense, it is transparent, and everybody knows this is a mechanism that transfers money from the young to the old. And the political support comes because everybody believes that they will become old and benefit from the money they pay in when they're young. It is not to somebody else, it's money from oneself to oneself, and that helps retain the political support. Medicare has 4 parts. Part A is a mandatory program that is insurance for inpatient events inside hospitals. Part B is a voluntary program, but even though it's voluntary, it's so well subsidized and such a good deal that almost everybody says, yes, I'll take Part B. And Part B is insurance for outpatient services. Part C was a latecomer to Medicare. It came in after the program was designed as a way to develop a managed care approach to Part A and Part B. So it combines hospital care and outpatient care as one package, and that's also been called Medicare Advantage Part C. They're synonymous. Part D was started in 2006 as a program to cover prescription drugs. So let's just go over the timeline. Medicare was started in 1965 to solve a problem because before 1965, half of all seniors, sometimes more than half of all seniors, lacked health insurance, and so becoming old meant you were sick a lot and you lost your income and you lost your wealth paying for expensive health care. So there was a lot of people who cared about seniors, and politicians who wanted to get seniors to vote for them said, if we solve this problem, we're going to be pretty popular. And so in 1965, Medicare passed through Congress. It did have some bipartisan support, although it was led by Democrat, especially Wilbur Mills. And in 1980, one big development was that the federal government allowed supplemental insurance plans called Medigap to come in and pay the co-pays and things that Medicare didn't cover. They were all federally regulated. These are private policies that you can buy or have your employer buy for you to pay for the co-pays and deductibles in Part A and Part B. In 1983, a cost control measure called diagnosis-related groups, DRGs, was brought in, and we'll be talking about DRGs in just a moment. And this was a shift to prospective payment to help control costs under Part A. In 1997, Medicare Advantage started, Medicare Part C, and in 2006, Medicare Part D started. One of the reasons to bring up Medicare is to talk about the economics of it and how Medicare used economic theory and economic evidence to try to address this problem of rising healthcare costs. And the mechanism that was started in the 80s was called diagnosis-related groups. Diagnosis-related group, or a DRG, is a way to shift from retrospective payment to prospective payment. In retrospective payment, which was how Medicare paid and many insurance companies paid, hospitals send the bill to the insurance company for tests and drugs and procedures, and the hospital gets paid for the full cost of these services, whether they were capital or labor. The hospital was made whole for all the things that it did. After 1983, there was a shift to prospective payments. That means that the hospital knows that no matter what they do, there's going to be one payment for that diagnosis. For example, patient comes in, a case of simple pneumonia. The hospital sends the bill to Medicare. It says, we took care of Joe who had simple pneumonia. That was DRG/089. And Medicare says, great, we know exactly what to pay you. That diagnosis has a weight of 1.07. So we will multiply 1.07 times your base rate of $5,000, and we will pay you $5,350 for Joe. No matter what you did, no matter how long he stays there, as long as his diagnosis remains simple pneumonia, you're going to get $5,350. If Mary comes in with septicemia, hospital says Mary was here with septicemia, she had DRG 416, please pay us. And Medicare says, oh, septicemia, we'll look that up. Weight is 1.3, you're going to get $6,500 for Mary. So it's capitated, and the hospitals know from the outset that no matter how many tests, drugs, and procedures they do, they're going to get the same flat fee. So the retrospective payment, the patient comes in and the hospital sees patients as money makers, that everything you do for the patient, you're going to get paid for. More tests, more drugs, more procedures, do. And in prospective payment, you have to not get sued for skimping on care. You have to take adequate care of Joe and Mary to make them not sue you and to maintain a reputation, but you don't want to do anything extra. And frankly, you want to get them out of the hospital because every extra day is extra labor. So the catch here is when you're starting a program like DRGs, you don't know what to pay the hospitals. And so there's this burn-in phase for the government to learn what the DRG weights have to be. So here's the problem. In establishing the payment schedule in DRGs, the government wants to pay the marginal cost. They want to pay just the extra money that the hospital had to put up to take care of each individual patient. So you just can't go to the hospitals of America and say, we want to know your marginal cost for a case of simple pneumonia. They don't often know for sure, and they're not going to tell you the truth. They're going to try to inflate it because they know what's up. They know that you're going to pay them based on what they tell you. So the government's pretty clever. It says, look, hospitals, we're not going to ask you what your marginal cost is. We're going to look at your market, and we're going to look at the charges we've been getting from all the hospitals in your market for the simple pneumonias and the septicemias and et cetera. And after 2 to 3 years of watching what you charge us, we're going to start paying you the charges of the most efficient hospital in your market. Well, now, during this burn-in learning phase of the DRGs, each hospital has no choice but to try to be as efficient as its competition. It's going to start submitting charges that are closer and closer to marginal cost, and the hospital, as it looks around that local market, will learn a number that is going to be close to the cost. So it's an evidence-based way to pay for diagnoses. So that's how that problem was solved. Now, part of what can happen, let me just go back one slide, is that when Joe comes in with simple pneumonia, and you know that if you call it simple pneumonia, you're going to get $5,350, what you'll do is say, Joe, it wasn't such a simple pneumonia. Guess what? It was a complicated pneumonia, and please pay us a DRG with a weight of 1.2. And upcoding is highly suspected. It is common in hospital every time they submit diagnosis. Now, you can't just lie. You have to show Medicare the chart, and they can look through Joe's medical record and say, oh, okay, I guess it was a complicated pneumonia, and we'll justify it. But now that we've got this arms race, we've got the billers and coders making the chart look good for Medicare on the hospital side, and we have chart reviewers on the Medicare side looking at every payment, looking at every chart and saying, was it really a complicated pneumonia? So this fight to establish the complexity of each DRG bill submitted is extra cost. You've got to hire people to argue over the bill inside Medicare. So the incentives are clear under retrospective payment. The hospital has moral hazard. It has an incentive to use as much labor and capital as they like. They could do what they like. Doctors and hospitals love this. It feels good to say, I am doing everything possible for my patient. I am not skimping on anything. That's the golden age of pre-DRG medical practice. Under prospective payment, the DRG does what capitation does, and it will cap your variable cost per Medicare admission. It doesn't really cap your capital costs. Again, you're submitting a DRG for Joe's stay in the hospital, and so you want to stop that length of stay. However, because of Joe's shorter stay, it doesn't mean you're not going to buy another CT scanner or build a new wing on your hospital. It means you're going to try to skimp on labor and try to hire as less nursing costs, less medical technician costs, because that's your variable cost. That's what's being choked off under the DRG system. It was recognized early on that under DRGs, there's an incentive to substitute away from labor into high-priced tech. If you can buy machines, robots, that help you take care of patients and get them out of the hospital faster, you will do that. You will buy more expensive drugs if they can shorten the length of stay. You will buy expensive machines if they can shorten the length of stay. You will build your own outpatient center if it can help you shorten the length of stay on that DRG, and then start charging Medicare Part B for outpatient charges or home care to take care of Joe when he's out of the hospital. So prospective payment has special incentives that move medical care in America into high-tech care and away from labor-intensive, stay in the hospital a long time styles of care. We'll see this coming up as a problem because we know that part of what's driving rising healthcare costs is this shift to high-tech care and a shift from inpatient to outpatient. And DRGs get credit for absolutely lowering the per diagnosis, per stay costs, but there's suspicion that the DRG system over the 10-20 year period has led American medical practice into this high-tech system that is driving the costs as the drugs and the machines become more intensive, more technical, and higher priced. Did it succeed on cost control? Well, the answer in the big picture of America is no. We have the highest costs now 30 years after DRGs. It didn't really constrain the widespread problem of American cost growth. And DRGs became the universal system of paying hospitals outside of Medicare. Now, private insurance companies also use the DRG system. But because they spurred this shift to high-tech intensive medicine and capital-intensive medicine, we got a cost growth problem. So in terms of cost control, not sure we got what we wanted out of DRGs and Medicare. However, the problem that Medicare wanted to solve was taking care of seniors. That question of did Medicare succeed is pretty persuasive. That life expectancy at age 65 increased dramatically in the years after Medicare came on. If you can see here, 1960, a person age 65 could expect to live 14 more years if they were black, 14 and a half more years if they were white. After Medicare, there was this big bump for both blacks and whites, a bigger bump for white people in America. It's America. We have very commonly seen gaps between who benefits from social programs, and white people have historically done better from government policy, and Medicare is no exception. So the gap between blacks and whites in life expectancy really increases a lot after Medicare comes on. After the 2000s, the gap narrows a little bit, but it's wider than it was in 1960 in life expectancy, and now there's about a 1 to 1.5 year gap in life expectancy for seniors based on race in America. We'll spend a whole hour talking about racial disparities in health later in the course. So what are the future prospects? Well, Medicare is loved in America. Political support for Medicare is quite high. People on Medicare love it. They don't want it to go away. People who are opposed to universal health care for people under 65 still support Medicare, which is why some of the people in the Democratic Party have been running on a campaign to say, if you like Medicare for people over 65, why not under 65? It is a national health insurance plan. It is socialized insurance. It's not socialized medical care. But it's a prospect that will continue to loom in American policy because it offers our experience basis in how to run a national program in health insurance. It's just that we only do it for seniors. There are a couple of experiments that are a little bit beyond what a DRG is doing. In a DRG, you get a prospective amount per diagnosis. Global Budgets is a version of Medicare that Maryland has and no other state in America has. The global budget payment system under Medicare in Maryland is that every hospital is told, I don't care what your DRGs are, Johns Hopkins Hospital or, Union Memorial Hospital, your budget next year is $100 million, period, for all of the patients that walk in your door. We've been watching you for the last 5 years. We know how many people walk in your door, and we know what we think it should cost to run your hospital for a year, and you're only going to get $100 million from the state of Maryland, who is going to consolidate all of the Medicare money in our state and pay you a flat payment. So now the hospital has an incentive to control all of its costs, its capital costs as well as its labor costs. This Medicare experiment in Maryland has been allowed in Maryland by the federal government on condition that Medicare's healthcare costs do not rise faster than the national average. So far, so good, barely. Maryland has been able to keep its cost growth lower than the national average, but it has had to tinker and tinker with this global budgeting system. We'll talk about the global budgets later in the course, but it has an incentive for hospitals to control all costs. It also occurs to people in public health that global budgets give you an incentive to try to make everybody around your hospital not get sick. And the question whether hospitals actually do that in Maryland, are they incentivized to make their city healthy? Well, they are incentivized. Do they do it? Do they know how to do it? These are terrific questions. Finally, future prospects are for Medicare to begin to use its immense bargaining power to negotiate lower drug prices. This has come up in Congress many times and has been voted down because political interests. There are many political arguments that say if Medicare starts to push down drug prices, innovation in pharmaceuticals will disappear and we won't get any brand new innovative drugs, etc. Too much intrusion of the government into private business interests. So we have not yet used Medicare's power to negotiate drug prices, although many other countries do that. That's our lecture on Medicare, and I hope to talk to you again as we come back and talk about the Medicaid program.